My name is Harsimrandeep Pahadi, and I am a PGY2 at the Las Palmas del Sol Internal Medicine Residency Program here in El Paso, Texas. Today I'll be presenting a fascinating case of acute colonic perforation with septic shock, secondary to disseminated histoplasmosis in an autologous bone marrow recipient. Histoplasma capsulatum is an opportunistic pathogen which can lead to a wide variety of clinical presentations in the immunocompromised host. Post-transplant histoplasmosis and hematopoietic cell transplant recipients is exceedingly rare with an annual incidence of less than 1%. This patient is a 71-year-old male with a past medical history of hypothyroidism, multiple myeloma, who had a autologous bone marrow transplant in 2018. He initially presented with a chief complaint of progressive weakness associated with shortness of breath. Initial review of systems was pertinent for anorexia, fatigue, and shortness of breath. He denied any fevers, chills, or cough, and the patient denied any similar symptoms in the past and denied any aggravating or alleviating factors. Initial vitals were notable for tachycardia and mild hypoxia. Initial laboratory evaluation was remarkable for pancytopenia. A chest x-ray was performed on admission and was largely unremarkable, but did reveal minimal subsegmental atelectatic changes at the right lung base. There were no focal areas of acute airspace disease, and this can be seen in Figure 1. Given the patient's history of malignancy and high clinical suspicion for pulmonary embolus, a CT angiogram of the chest and thorax was obtained, which was negative for pulmonary embolus, but did reveal a small cavitary lesion in the left lower lobe, as seen in Figure 2, highlighted by the red arrow. The patient was empirically initiated on cefepime and mycofungin due to suspicion for disseminated fungal infection. On hospital day 3, the patient acutely decompensated and went into septic shock. Physical exam findings were consistent with an acute abdomen. A stat CT of the abdomen and pelvis was performed, revealing free intra-abdominal air concerning for a bowel perforation. Figure 3 demonstrates this intra-abdominal free air as indicated by the red arrow. The patient was subsequently taken for an emergent exploratory laparotomy with right hemicolectomy due to a perforated cecum. Post-operative pathology evaluation of the cecum revealed a diffuse histoplasma capsulatum seen in Figures 4 and 5. We can see diffuse clusters of histoplasma capsulatum in these two figures. Bone marrow aspiration was performed, which also revealed diffuse histoplasma capsulatum. This can be seen in Figure 6. The patient was then placed on lipophilic amphotericin B as per IDSA guidelines for the treatment of disseminated histoplasmosis. The patient's postoperative course has been complicated by the persistence of septic shock and metabolic encephalopathy. Histoplasmosis infection in immunocompetent patients is typically asymptomatic, whereas immunocompromised patients can often experience severe life-threatening disease. Endemic areas within the continental United States include the Mississippi and Ohio River valleys. Disseminated histoplasmosis is exceedingly rare, especially in patients who have undergone autologous hematopoietic cell transplant. Very few cases have been described in such patients, especially in non-endemic areas, such as the southwestern United States. Acute colonic perforation has been rarely reported and should be in the differential of patients who present septic, especially when they're immunocompromised. Current IDSA recommendations include treatment with lipophilic amphotericin B for 1 or 2 weeks, followed by oral itraconazole for the following 12 months. Despite this aggressive antifungal regimen, the prognosis for patients with disseminated histoplasmosis remains grim. To summarize, this patient presented due to weakness and shortness of breath. Imaging findings revealed a small cavitary lesion for which broad-spectrum antifungals were initiated. The patient then became septic and was found to have an acute colonic perforation, which was later attributed to disseminated histoplasmosis upon microscopic evaluation. We hope that this case can highlight the importance of maintaining a broad differential in the workup of immunocompromised patients. Thank you for listening.